This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. This is Andy Southerland from the University of Virginia, and I'm very excited to be speaking with my friend and colleague, Amrou Sarraj, who is the George M. Humphrey II Chair and Professor of Neurology at Case Western Reserve School of Medicine and Director of the Comprehensive Stroke Center at University Hospitals Cleveland Medical Center. For this week's Neurology podcast, we're going to be discussing an article recently published in the journal titled General versus Non-General Anesthesia for Endovascular Thrombectomy in Patients with Large Core Strokes, a pre-specified secondary analysis of the SELECT-2 trial. The SELECT-2 trial was a prospective randomized trial that showed benefit of endovascular thrombectomy in patients with large core ischemic strokes, defined by aspect score of 3 to 5 on non-contrast head CT, or an ischemic core greater than or equal to 50 milliliters on CT perfusion study. Primary trial results were published in New England Journal in 2023. And today we're going to be discussing the results of this pre-specified analysis comparing patients who received general versus non-general anesthesia in the trial. So Amrou, always great to have you on the podcast. Thanks for joining us.
Thank you so much, Andy. A pleasure to be with you.
Fantastic. For our audience who may not keep up with this literature day to day in the realm of vascular neurology, acute stroke treatment, there have been numerous prior studies, meta-analyses of clinical trials that look at this sort of question of method of anesthesia in patients undergoing endovascular therapy for large vessel occlusion stroke. One might ask, why is it important to readdress this in the SELECT-2 randomized trial of patients with large ischemic stroke, and specifically those with large ischemic cores prior to the procedure? What is the relevance that sort of led you and your team to want to pre-specify this as an important analysis?
We are all approaching uncharted territory. Till 2 or 3 years ago, it was for long believed that patients with large ischemic core, those with low aspects, early ischemic changes on the CAT scan, aspects of 5 or less, and just in brief, the aspect is a measure for good imaging profile or poor imaging profile, small core or large core, in patients presenting with large vessel occlusion. And the prior trial showed benefit in small core, excluded patients largely with aspects of 5 or less. And the core is measured on the perfusion images. Those were areas that studied in research before and showed that patients who have regional cerebral blood flow less than 30% as compared to a normal territory would have irreversible ischemic changes when you follow them on MRI at 72 hours. So those patients were excluded from prior trials, were excluded from our practice largely. They were not part of guidelines. They were not part of practice guidelines at the different facilities, because of inherited beliefs that they will not benefit. Rightfully, the risk and benefit risk is not well established because you have patients with large cores. Unlikely they will do as a natural history, but also the potential benefit is not high because they have large strokes. Just having any large MI, a very large subarachnoid hemorrhage, prognosis is not good, and the risk of hemorrhagic transformation is high because you are reperfusing large area of infarct. So now, as we studied those in the SELECT-2 trial and showed benefit of thrombectomy in this population, as other 5 trials, randomized trials across the world, reported benefit. The tension trial in Germany and Europe and Canada, the Angel aspects in China, the Rescue Japan limit in Japan, the LASTE trial in France, and finally the Tesla trial, which also showed either benefit in 5 trials or same direction with per protocol benefit in Tesla. Now those patients became part of the practice. They are being treated. Guidelines have been changed, and the Australian guidelines have been changed. The American Heart Association, hopefully soon. As far as I know, this is in advanced stages. The SVEN guidelines included these patients with aspects of 3 to 5, 0 to 24 hours. So when these become part of our practice, we need to know how to approach these patients. And anesthesia is one of the important tools that is associated with the procedure. Should I put the patient under general anesthesia, or should I treat them with local or conscious sedation? That's the first part. The second part, while we showed benefit in this population, we and others, the outcomes remained not as good as we want them. But by nature, these patients have very large strokes. You are not expecting the 60-70% independence rate or modified Rankin scale of 0 to 2 at 90 days. We observed somewhere around 20% rate, but it's better than medical management of around 7%. We observed 40% independence mobility in MRS of 3, which is excellent outcome. 40% of patients with very large infarcts being able to walk independently at 90 days as compared to doubling this in medical management. But we want to optimize these outcomes. We want this 40% to become 50 and 60. We want this 20% with functional independence to be 30 and 40%. So it's these ancillary variables, the anesthesia, the blood pressure, be it adjunctive therapies and reducing the edema, being hemicraniectomy, or being devices and different procedural approaches. These are the ancillary variables that would help us optimizing the outcomes. And that's why we thought this would be an important question to shed light on.
And that makes complete sense, Amrou, that not only, as you point out, were these patients more or less excluded from prior trials, so it's hard to extrapolate anything from how they would do based on our prior trial experience. There are legitimate biological, physiologic reasons why people with large ischemic cores, large strokes, would respond differently to different methods of anesthesia, may have different degrees of variability in their vital sign management and so forth, both during and after the procedure. So naturally, it is a very important question to readdress. Getting right to it, what were the main findings from this sub-study that you all recently published?
We asked the question, would patients with conscious sedation or with general anesthesia have better association with clinical outcomes after thrombectomy? So this is only in the thrombectomy population, not in the medical management population, when compared to each other on the 90-day outcome. And overall, we found no difference. There was no difference in the modified Rankin scale, which is the functional outcome at 90 days. And we looked at 1 year because we have 1 year in Select 2. There's no difference in independent ambulation between general anesthesia and conscious sedation. As you may imagine, patients who receive general anesthesia take longer time to start the procedure. So from randomization to doing the groin puncture, it was longer and it was statistically significant, but it was not associated with worsened outcome. There was no difference in infarct volume, and we limited then the population to only the patients who got successful reperfusion, MTK, to be more, and there was no difference. And we tried to look at interaction with the collateral status, stroke severity, the aspect score. There was no interaction. And going back, the reason why we would think that one would be different than the others, and I would say I was one of the people who thought that, especially in this population, patients with conscious sedation will do better. These are large poor patients, and you're worried that by doing general anesthesia, the blood pressure will drop, and you will lose collaterals, and you will make what's already a large infarct larger. So the patients will end up doing worse. So that's the hypothesis when we asked the question. And actually, to be fair, while we did not specify conscious sedation versus general anesthesia in the protocol, we recommended that the sites would do conscious sedation. And because it's not mandatory, the sites went on and did what they did. And that would be my message to people in practice afterwards. We ended up with 60% of the patients receiving general anesthesia. So people did what they wanted to do. And they proven to be right because there was no association between the type of anesthesia and the outcome.
And you bring up a good point there. It does allow some flexibility in practice in folks who really were convinced one way or the other. And I agree with you. It is I would probably lean towards your hypothesis leading up to the results of the study, but it wasn't randomized. People did do what they wanted to do. And so there's some inherent selection bias in that. How do you think these results will affect current practice? Have they affected your own practice? And then what are some of those key limitations that we should keep in mind as we're interpreting the results of this sub-study?
Sure. As you mentioned, we did not randomize on the anesthesia type. There were trials randomized on the anesthesia type. Back a few years ago, the belief again was that conscious sedation will result in better outcome. It started with sub-analyses from the Hermes showing better outcomes with conscious sedation or local anesthesia as compared to general anesthesia. Then the randomized trials, the siesta and N-stroke, showed no difference. The Goliath and the individual patient data meta-analysis of all anesthesia, general versus non-general, showed better outcome with general anesthesia. From the paper that we published from Select and Extend IA in Neurology a few years ago, general anesthesia was associated with worse outcome, higher neurological worsening, and worse effect in collaterals. And that's why we hypothesized, and that's why we recommended in Select 2 that people do conscious sedation. Why the results are different. And this is a major point that people should take into their practice, should take into their research. There is a difference between causation and association. A lot of times, and we saw this over and over, in blood pressure management, you come and do a sub-analysis of a retrospective study, and that patients with lower blood pressure ended up doing worse or better. And then you come and say, lower blood pressure resulted in improved outcome. No, it is association. It is not causal relationship. And that's why the trials that did intensive blood pressure management actually showed that patients do worse with intensive blood pressure management. It's the same concept when it comes to this. What we are learning and what we learned, that the effect of endovascular thrombectomy and reperfusion is pretty strong and overcomes a lot of the ancillary variables around it. Of course, we try to optimize everything, but optimization does not always mean this way or the other. It might be your way that you do it best for the patients. If you are doing general anesthesia and you keep the patients not moving and your complication rate with pneumonia and other things are not high, and you don't drop the blood pressure during the procedure, then go ahead and do it. If you do conscious sedation better and you say my dissections rates are not too high and I'm not going to have complications, then go ahead and do it. And that is actually help, because people don't need to change their protocol and say, well, for 15 years I have been doing conscious sedation and now you're coming and telling me to go ahead and do general anesthesia or vice versa. Not at all. As long as you and your team are comfortable with the procedure, there was no difference in this specific variable when it comes to outcomes. When it comes to limitations, and why I want people to, when they read or when they see something, say, I'm not sure I agree with this. Of course, this is non-randomized. I have news for you. I highly doubt that you will ever have this question being randomized. I just spent 5 minutes talking to you about causation and association, so you should not be asking this question again in this manner, because it's unlikely that you will find this type of answer. Maybe when you have larger sample size, you would know better because you will have more power. But I will have my reservations on the conclusions, because this is clear to me at this point. The multitude of these ancillary variables would have some sort of effect, but them individually is unlikely unless there is something that we are systematically doing that would result in derailing the patient's outcomes. And we are finding from Select 2 and from prior studies that actually it's not the case with anesthesia.
You bring up a number of good points there, but importantly, even if there is some selection bias, as long as people are selecting based on their level of skill and comfort in reperfusing the brain, it's a really strong message from the entire body of this work, which is that the brain, even in the setting of large ischemic core, large strokes, perfusing that brain cures a lot of ills and washes out a lot of other ways that we try to optimize patient care. And that's an important message to take away.
It's really what you learned early in your residency, and which you will continue to teach residents probably till we get to a point that stroke is a clot in the blood vessel, prevent flow to the brain, and the mainstay is, and will always be reperfusion. Opening the blood vessel beats not opening the blood vessels 8 days a week. The other variables important, the nursing care, the other things, absolutely. But spending resources, just the message is go ahead and perfect what you do best, and you will have good results, better results than medical management in this population.
Valid point. And as you say, I tell my residents and students all the time, the brain doesn't care how it gets blood flow back as long as it happens and you do it as safely and quickly as possible. That's the main message. Speaking of which, and all this ongoing richness data that come out of Extend IA and now the select research trials, what am I going to be interviewing you about on the podcast next? What excites you most about the next steps? And
it's always wonderful to be with you, Andy, and to look at the future. So we have done a lot of analysis from Select 2. It would be worth mentioning. We are up to the 16th or the 17th paper. A few important points to highlight. We looked at 1-year outcomes, and this was published in Lancet, and patients continue to improve. You have 20% of the patients who continue to improve between 90 days and 1 year. Very important that you are patient with your patient. Scott Kastner published a very nice paper on nihilism and hemicrania versus no hemicrania and early withdrawal of care, and patients do worse when we think they will do worse. So give the patients opportunity. You don't expect patients who have reperfusion of very large core to be running down the hallway on day 2. Rehabilitation works. It may take longer, and actually it opens the doors. Do we need to do longer than 3 months or outcomes up to 1 year? No difference in hemicrania versus no hemicrania. So don't be shy if you needed to do hemicrania for these patients, and relieving the pressure and giving them an opportunity. No difference between men and women. Very important message. The frailty in women of older age, you may predict worse outcomes. This was not the case. Cost effectiveness in different healthcare system, and that's important to the healthcare systems to adapt this in the United States, in Europe, and Australia. Different imaging modalities, CT aspects, perfusion, which we mentioned originally, no difference. So this is refreshing that this became, as well, guidelines may take a little bit of time. This became part of the practice. You and I can attest to that, and many people already changed there because they see the evidence. So next is a few things that we still need to understand and to optimize things is the treatment benefit in this population. What was it driven by? Reperfusion part of it, decreasing final infarct volume part of it. What is the role of cerebral edema? What is the 1 + 2 + 3 equals percentage of the improvement? May not be from a single trial, may need the collective data, and it's good to share with your audience that the PIs for all the randomized trials agreed a few months ago to proceed with a meta-analysis of this population to shed light on the subgroups, because there's no single trial's power to tell you, is it beneficial more than 150? Do you have a higher limit? What about early window versus late window? Even the question that we just discussed about anesthesia and blood pressure and all of that. So this data will be presented in its first shape at the World Stroke Conference in Barcelona next month, the Atlas meta-analysis. And will be, again, reread all of the images by independent core lab with Dr. Campbell in Melbourne, and then we'll probably represent the data and publish it to shed light and look at all of these subgroups. How can we optimize the patients? How can we enhance the outcomes for this population to get patients? Because this is why research is done. It's not just to answer my curiosity or yours, is to bring questions that will bring new treatments to patients and new populations to get patients back to their family and to the society, sound, healthy, and probably productive part of the society.
I believe that you're also going to be looking at patients who present after 24 hours from last known. That is still an area where there's some equipoise. These patients that present very late from time of last known. Correct me if I'm wrong, this will be the Select Late trial that we're hoping to get off the ground and learn some from soon.
So for a long time, and that's the nature of a human being, operated on having a line in the sand for time. Patients with TPA first 3 hours, then 4.5 hours. Thrombectomy first 6 hours, then 24 hours. But what about the population that may present beyond 24 hours and might still have viable brain tissue to be treated? We're looking at this in the SELECT-LATE trial, and hopefully we partner on this with you in the population in the University of Virginia. Currently, this is another uncharted territory. So size is done. What about late? What about time? Can we open the door for those patients who may present 2 days from their last one? Well, more than 24 hours. And if this is shown to be positive, and we published the cohort multi-center international study about this and showed potential benefit, so we're randomizing the patients. If these patients would benefit, this would change a lot. This would change our systems of care approach, transferring patients, all of that. But it's all would be for the good of the patient. And this might be a few years away. It's a grant from the patient-centered outcome, and I'm really happy to partner with you and other colleagues on this to bring an answer to this important question.
Fantastic. That's a great message to end on, and certainly sounds like there's a lot of ongoing collaboration that will lead to even better analysis from these collective data within that Atlas consortia. And we'll be excited to hear about that. And perhaps we will bring you back on to tell us about that once it's presented at World Stroke Congress next month. But in the meantime, I want to thank again my colleague Amrou Sarraj for joining us with the podcast to discuss this paper, again titled General versus Non-General Anesthesia for Endovascular Thrombectomy in Patients with Large Core Strokes, a pre-specified secondary analysis of the SELECT-2 trial. Seek out the main paper in the Neurology Journal and look forward to this and other podcasts on the topic. Amrou, thank you so much again for joining us.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.